Hi, everybody, and welcome to this debate. I'm Dr. Frank Phillips with Midwest Orthopaedics at Rush, where I practice as a spine surgeon. I'd like to thank you all for joining us in the case debate series hosted by Nuvasive. You'll get to hear your peers go head-to-head in these debates, sharing their philosophies of procedural approaches, as well as how they apply the different technologies in their practices. With that, I'd like to kick off the next debate in our series. Thoracolumbar procedures, Open TLIF versus MIS TLIF. And we have Dr. David Okonkwo and Dr. Aaron Clark to discuss these procedures. Dr. David Okonkwo is a neurosurgeon at University Pittsburgh Medical Center, where he serves as the Director of Neurotrauma Clinical Trial Center, as well as the Director of the Scoliosis and Spinal Deformity Program. Dr. Aaron Clark is a neurosurgeon and Assistant Professor of Neurologic Surgery at UCSF Health. As you can see, we have two very experienced surgeons in this space, and once David and Aaron share their perspective, I'll provide some closing comments to bring this debate to a close. With that, I'll turn this over to you.
I'm Aaron Clark, and I'm a neurosurgeon at UCSF. I have a primary practice as a spine surgeon there with a focus on minimally invasive spine surgery. I did my training at UCSF and a fellowship in minimally invasive spine surgery with Kevin Foley in Memphis. Now, our audience may not know this, but both Dr. Okonkwo and I are products of the VCU MD PhD program. He graduated in the class of 2000 and I finished in 2008. So by the time I was starting, he was already a well-established researcher and neurosurgeon. And, as such, having lived in the shadow for over 10 years, I really have to say I'm grateful to Nuvasive for allowing me to argue on the side of MIS TLIF. And maybe I finally have a chance to beat David Okonkwo.
I am David Okonkwo. I am a neurosurgeon at UPMC in Pittsburgh, Pennsylvania. It's great to be here with my fellow alum of VCU, Aaron, and I appreciate his kind words, and it's an honor to be here representing our institution, which was very good to me and was vital in getting my career off to the right start. My practice runs the full spectrum from deformity through much more simple spine cases. The bulk of my practice is doing scoliosis and spinal deformity procedures, but I still have a significant degen practice ongoing. And I feel like I'm in a great position to work through these cases that we're going to discuss today with Aaron, because my skill set runs the full spectrum from the things I learned from Chris Shaffrey back at UVA, which would be maximally invasive but biomechanically pure open scoliosis techniques, all the way through minimally invasive one-level foraminotomies for people with radicular pain syndromes and everything in between. And Aaron's going to talk through a lot of the upsides of MIS TLIFs, and I employ MIS TLIFs strategically in my practice, but I do also continue to do good old-fashioned open TLIFs in selected cases. And it's nice to have that full spectrum of options in my tool belt and apply them strategically.
So based on my training, as I described in my experience, I'm biased towards MIS for most spinal operations. I think the cosmetic benefits are clear. You can do operations on even very large patients through bilateral 1-inch incisions, as you can see in a picture that I've included here. The functional benefits of minimally invasive approaches stem from using normal tissue planes and tubular dilators to preserve as much soft tissue as possible, as well as limit the approach-related morbidity. But the big question is that the original Open TLIF, which Dr. Okonkwo is going to describe, is a great operation. It's been done for decades and decades with good results. So can minimally invasive TLIF accomplish the same goals? And those goals are obviously decompression, fusion, and realignment if needed. And I believe the answer is yes. By appropriately placing the retractor and adjusting it as needed, all stenotic areas can be decompressed. By paying close attention to arthrodesis, solid fusion can be generated. Much like we both teach our residents, a lot of spine surgery is good carpentry, and spending the time removing all the disc and the end plate is critical. A tube can even be placed on the contralateral facet to decorticate that as well for fusion. And then for realignment, if you max out the length of the PERC screws with reduction towers, like the NuVasive Reline system, that does allow you to reduce spondylolisthesis. So if minimally invasive can accomplish the same goals as open surgery, why aren't we doing it? And some of the common criticisms are it's harder, there's too many complications, and exposes the patient and their surgeon to excessive radiation. Now, these issues all stem from the same issue, which is the learning curve. And that's been described in the literature for surgeons adopting minimally invasive TLIF and really MIS surgery in general. The initial cases that a surgeon performs are going to be longer. They may have more complications, and they're definitely going to use more fluoro time. Really, depending on the paper you read about this, including a study from UCSF, it takes about 10 to 40 cases to get over that learning curve. So it is a commitment. One common complication that's described is CSF leak. Interestingly, though, if a dural tear occurs, this sometimes happens to me, obviously never happens to Dr. Okonkwo. The lack of significant postoperative dead space really prevents CSF leaks from being an issue postoperatively. And radiation time can, of course, be decreased with surgeon experience and also by using new technology like navigation. So are there additional benefits that might get a surgeon to work through that learning curve? And some of these advantages have been well described. There is significantly lower blood loss. There's lower infection rates postoperatively related to more vascularized tissue, closing down the dead space and not needing a postoperative drain. There's less pain postoperatively, leading to a shorter recovery time. And it's also been described in certain patient populations like the obese, they may have more complications when they have an open TLIF, but that same population doesn't have that increase in complications if they're done MIS. And this was initially described by Paul Park. And actually our moderator, Frank Phillips, also published a landmark paper on this subject, showing here shorter length of stay, shorter surgical time, which highlights that in the hands of a experienced and gifted surgeon, MIS can actually be more efficient, lower blood loss, and less pain. And although the implant costs may be higher, all these other factors actually can lead to an overall lower cost for MIS TLIF. And lastly, what about lumbar lordosis? Because it's important to remember with MIS, you have really no access to the midline structures, and it's a little bit more work to remove the contralateral facet if you need that to induce lordosis. However, I do have this slide, which has some unpublished data of 160 cases that shows if you do MIS TLIF, there is no loss of lordosis, maybe even a slight increase. And again, patient selection is critical. In my hands, a patient that needs a lot of lordosis probably needs a different operation than a TLIF. And also, like I mentioned before, that good carpentry, placing the cage anteriorly, gentle compression over the screws, and if possible or if needed, remove that contralateral facet.
Thanks, Aaron. That was a fantastic quick overview of a lot of the advantages of minimally invasive TLIFs as we apply them to spinal degenerative disorders. I'd like to emphasize one of the topics that you touched upon with navigation. And in my own practice, I have been very much an embracer of assistive technologies beyond just navigation. And I think that the more assistive technologies we bring to bear, the safer, more predictable, and better our outcomes will be with MIS TLIFs.
So let's go ahead and get started with case one. This patient is a 48-year-old female. She has not had any prior spinal surgery, but she does have severe low back pain radiating into the left leg. And the imaging which we're going to see is going to demonstrate a left facet cyst with spondylolisthesis at L4-5. She has severe pain, rated 9 out of 10 on the visual analog scale. Here we see her preoperative lateral radiograph showing her spinal pelvic parameters. She has a moderate pelvic incidence at 63, which is well matched by a lumbar lordosis of 62, and only a -1 degree of mismatch. Her pelvic tilt is 22. And on her MRI scan, we see a very large left-sided facet cyst emanating from the L4-5 facet joint, causing severe stenosis of the lateral recess and compression of at least the L5 nerve root in the lateral recess. On flexion extension views, we can see the extent of the grade 1 spondylolisthesis and perhaps a small amount of accentuation of that malalignment on flexion. And from there, we can move into our discussion about what we think would be the optimal treatment for this patient.
Aaron, there are a lot of thoughts that go through my mind when I'm working through a patient with this presentation, seeing them in my clinic. And we have a scenario where a patient has an L4-5 synovial cyst and a grade 1 spondylolisthesis at L4-5. And she's having a component of back and left lower extremity pain. She's not having pain in the right leg. And this case is a conundrum facing spine surgeons going back decades. There are still a fair number of people who would look at this case and say that a unilateral one-level decompression is a perfectly reasonable option in this situation. And there are a host of other folks who would view this as a case that has an indication for fusion. My old mentor, John Jane, his perspective was always that a facet cyst, a synovial cyst, is de facto evidence of instability. And in his mind, he was less concerned about what the flexion extension films did or did not show. He assumed that there was instability with every one of these cases. And I will tell you that that has creeped into my own practice and my own thought process for patients with synovial cysts. To me, the treatment options here are a unilateral, minimally invasive foraminotomy resection of facet cyst, but we could also consider an open TLIF as well as a minimally invasive TLIF. And I would spend a fair amount of time in clinic with this patient really trying to understand the extent to which it is mechanical back pain versus a back pain component that seems to be associated with that radicular pain syndrome that's plaguing her. And I'll turn it over to you.
Well, Dave, I think those are great points. And also, I agree that this is a very challenging, in some respects controversial, initial decision-making process, whether to do just a simple decompression versus a fusion. I do, in my practice, for patients that have small facet cysts and no spondylolisthesis, offer a minimally invasive decompression with just resection of the facet cyst, always with a conversation between myself and the patient describing that there is a risk that the facet cyst can recur. However, in this patient with spondylolisthesis, a very large facet cyst that I believe would require resection of most of that facet to fully decompress the nerve root, I think that this is an indication for fusion, at least in my practice. And as you highlighted, really patient selection and selection of the appropriate surgery is critical with this and with all spine surgery. In this situation, I think that MIS TLIF really is perfect, and there are a couple of reasons why I think this. One is that the patient has a relatively low pelvic incidence, and this means that the patient doesn't need a tremendous amount of lordosis. The second thing is that the disc is relatively tall, and I think this is important to remember because with minimally invasive surgery, in particular minimally invasive TLIF, you don't have the ability to use a laminar spreader to open up that disc space to do all the preparation and discectomy. Also, the patient has a grade 1 spondy that, particularly based on the difference between the MRI scan and the x-rays, I think that that's almost likely going to reduce on the table. And lastly, the pathology is unilateral, and this facet cyst will be completely removed with a simple docking of the tubular retractor right on the facet to remove both the facet to do the TLIF as well as the associated cyst. So I really think this is kind of a slam dunk for an MIS TLIF, and I think a lot of these characteristics make it a relatively easy one to where even someone progressing through that learning curve could consider this for one of their early MIS TLIF attempts.
Aaron, I think that is a very thoughtful approach to this case. And I think one of the key things that you said was that this is a spondy that's very likely to reduce just with good positioning in the operating room. And in this situation, my bias is actually to agree with you. And not every debate needs to involve oppositional sides. In this situation, I would fall back on the wise words of my old mentor, John Jane, and I would look at a synovial cyst of this size and this magnitude in the setting of this spondy, and I would agree that this is a fantastic patient for a minimally invasive TLIF. As you can see, the treating physician in this case agreed with our perspective as well, that this patient was ultimately treated with an L4-5 MIS TLIF. The surgeon chose to use an oblique peak cage, which I think is a very reasonable and rational choice. In my practice in 2020, I have virtually entirely shifted away from a traditional peak cage and over towards 3D printed titanium cages and taking advantage of the advanced material properties of the latest generation of implants for TLIFs. But apart from the choice of the interbody implant, I would have performed the same surgery for this patient. For this particular patient, one of the important concepts that the surgeon successfully achieved was to preserve the patient's spinal pelvic parameters following surgery, and the PILL remains matched. And I suspect that this patient is on her way to a better quality of life. Well, great, one case, and we seem to agree. So let's see what happens with the next one. For our second case, this is a 68-year-old female. She had a lumbar discectomy 5 years ago. She did well following that operation initially, but over the last 3 years, her back pain's been getting worse, and she now has 1 year history of bilateral radicular pain that is worse on the right. Here is her preoperative imaging. As you can see, as opposed to the first patient, this is a patient with a higher pelvic incidence, and now we're talking about a higher sacral slope, higher pelvic incidence of 74. She's got a PILO mismatch of 16 degrees, and she's compensating with that 36-degree pelvic tilt in an effort to try to maintain her posture. And her CT myelogram shows that there is collapse of that L4-5 disc, there is a grade 1 spondy, and there's a vacuum disc indicative of severe degeneration of that L4-5 disc. You can see that she has lost posterior elements at this level from her prior surgery. And on the axials with the CT myelogram, we see that there is facet arthropathy that's creating a foraminal problem that is of higher severity on the left. On flexion extension films, there is not appreciable instability, but redemonstration of that grade 1 spondylolisthesis and collapsed disc space. So Aaron, what are your thoughts on this one?
Well, I think that this is a challenging case for a couple of different reasons. One is the fact that the patient, as you've highlighted, has a high pelvic incidence. And as we know, when we're treating, in particular, spinal problems at L4-5 and L5-S1, we really want to achieve as much lordosis as we can from those two segments to generate a more harmonious spine. The second thing is that this patient's had a prior laminectomy. There is no spinous process and very little residual lamina at the L4-5 area where she needs surgery now. Thirdly, she has grade 2 spondylolisthesis and a virtually completely collapsed disc space. And I think all of those are challenging regardless of what type of surgery you perform, whether it's open or minimally invasive, but I think does generate specific problems when it comes to thinking about treating this minimally invasively. First off is, again, as I mentioned, you have limited access to all of the posterior elements when you're doing this through a smaller minimally invasive portal. And so questioning whether you're going to be able to generate the amount of lordosis needed is one important consideration. Second of all, the patient has had a prior laminectomy, and can minimally invasive surgery be done in the setting of a revision type operation? And in this case, I think that it can be done. And I've included a few slides from a minimally invasive TLIF that I did recently in a patient that had a laminectomy. And you can see that with appropriate placement of the tubular retractor over the residual facet, you can actually do this operation safely and expose Camden's triangle just like we always want to do, where you can see the disc, the traversing and the exiting nerve root, as well as the pedicle, and do a complete discectomy and cage placement. And this has actually been shown in the literature that in the setting of a revision type operation, minimally invasive TLIFs can generate similar, very, very good and reproducible results compared to the traditional open approach. The third question is, can MIS TLIF be done in the setting of a very, very collapsed disc where you just have less ability to distract that disc space, and also in the setting of a grade 2 spondy? And I believe that minimally invasive operation can be performed in the setting of a completely collapsed disc, and we just have to employ slightly different techniques. The technique that I use in particular is I'll slowly begin to distract that disc space open, taking advantage of the elastic properties of the spine, slowly opening that space. And once I get it to an appropriate height where I can do my discectomy and place my cage, I actually will place the rod on the contralateral side, hold the disc space open so I can get all my minimally invasive instruments in to do a complete discectomy to generate that fusion. And like I mentioned above, in the setting of grade 2 spondy, particularly when using long percutaneous screws with reduction towers, you can reduce a grade 2 spondy, particularly in this case when looking back at the CT myelogram and you see that there is a vacuum phenomenon in the disc space. To me, this means that that disc is going to move as you start manipulating the spine, and I believe that you could get a good reduction of this minimally invasively. So I think the big challenge here when thinking of a minimally invasive approach is really that high pelvic incidence. That I think is going to be challenging, but it also brings up the question of, is TLIF actually the right operation for this patient?
Aaron, you just raised a series of fantastic points, all of which are centered around achieving the appropriate goals of surgery for this patient. And those goals include neuroelement decompression, establishing a construct that will promote and achieve arthrodesis, as well as addressing the patient's spinopelvic disharmony. And all of those three things need to be achieved regardless of the treatment approach that is chosen for this particular patient. I learned many years ago from Frank Phillips that minimally invasive strategies can be safely and effectively applied to patients who have already had a previous decompressive procedure. And so an MIS TLIF is in fact an option for this patient, which Frank and others have shown repeatedly. But I will tell you that in my hands, the most predictable intervention for this patient is an open TLIF, where I would complete what a bilateral facetectomy, which creates, in essence, an osteotomy and allows me to truly mobilize that segment, get good disc distraction, get a well-placed anterior cage with a specifically chosen lordosis feature to maximize the likelihood of restoring this patient's spinal pelvic harmony. And that is one of the central tenets of treatment for this. We were able to show in our own hands, which we published a few years back in the Red Journal, that patients who are left with a pelvic incidence lumbar lordosis mismatch following just a one-level TLIF have extremely high rates of revision surgery in the years ahead. This doesn't mean that every patient with one-level disease turns into a deformity patient that needs a multi-level fusion, but it does mean that focusing on that third component of addressing the pelvic incidence lumbar lordosis mismatch during your procedure is not only going to help the patient now, but it's going to help the patient long-term by lowering the risk of reoperation. And that risk of reoperation is going to be a feature that all of us are judged more and more on in the years to come. So I respect the person who views this case as an MIS TLIF case, but I will tell you that in my hands, I would perform an open TLIF for this case, which gives me, in my experience, the greatest control over changing that PILL mismatch and achieving all three goals of my intervention. Well, Aaron, as you can see, the treating surgeon agreed with me. And in fact, this patient had an L45 open TLIF. You can see there's been really nice reduction. There is a well-placed anterior cage and compression posteriorly to change the PILL parameters. And you can see that now postoperatively, the pelvic incidence and lumbar lordosis are evenly matched, and the pelvic tilt has come down into a far more acceptable range. And I think that for this particular patient, this intervention carries with it a much more favorable long-term prognosis because the surgeon achieved that third goal of addressing the PILL mismatch.
Well, thanks for highlighting those very, very important points, Dave. And I would agree with you that looking at these x-rays, it does certainly appear that using the technique you described, this surgeon was able to achieve all three goals of this operation for this specific patient. And at the end of the day, I do believe this would be a very challenging result to achieve through a minimally invasive approach. Now, moving on to our third and final case. This is a 69-year-old male who has not had any prior spinal surgeries, but now has stabbing low back pain radiating into the buttocks as well as into the bilateral lower extremities. And these symptoms have been unresponsive to a full course of non-operative management, including physical therapy, injections, and activity modification. And he remains in excruciating pain, which he rates 7 to 10 out of 10. His preoperative AP and lateral radiographs show multi-level degenerative disc disease, as well as a low-grade L4-5 spondylolisthesis. And on his preoperative MRI scan, particularly on the axial view, you can see severe bilateral lateral recess stenosis with very significant facet arthropathy bilaterally, resulting in foraminal stenosis, as well as stenosis contributed by the uncovering of the disc space due to the spondylolisthesis. Moving on to his spinal pelvic parameters, he has a modest pelvic incidence at 55.8 degrees, which is relatively matched by a lumbar lordosis of 50.7 degrees and only a 5-degree PILL mismatch. A little bit of an elevated pelvic tilt at 28 degrees. So for this particular patient, I think one of the big issues to consider, and one area that may have some controversy surrounding it, is can a bilateral decompression be achieved for a person minimally invasively? For this patient, he has bilateral symptoms in his legs, and I imagine some neurogenic claudication as well. And can the left and the right side be adequately decompressed using a tubular retractor? And the answer to that, I think, is yes. There is plenty of data showing that the so-called uni-bi or unilateral approach for bilateral decompression can actually do a very, very comprehensive decompression of the central canal. In addition, by treating this patient minimally invasively, generating some increased disc height by the techniques that we discussed earlier through a minimally invasive approach, as well as realignment of that L4-5 spondy in conjunction with a unilateral approach for bilateral decompression, I think that all the goals for this patient can be achieved through a minimally invasive L4-5 TLIF.
Aaron, I agree with you that bilateral decompressions can be achieved with minimally invasive approaches. I think there are a couple other things to bear in mind about this patient that spill over into the broader concept of decision-making and surgical decision-making for patients with these kinds of spinal degenerative disorders. And what I would point out first is that the patient is 5'11", 240 pounds, which places his BMI at 33.5. And that raises two issues. The first is that in my practice, this patient would not qualify for surgery without weight loss. I don't operate on people with a BMI over 32. And I would strongly encourage this patient to lose weight. And in fact, I would help this patient understand why he is not yet a candidate for an intervention in my practice. And he only needs to lose 12 pounds to get himself under a BMI of 32, which carries with it several upsides, not just for perioperative risk, but for long-term healing. Having said that, in the grand scheme of things, the larger the human, the more advantageous minimally invasive approaches are. So if you're someone who tolerates a BMI of 33.5 in your practice, this person may actually have an easier opportunity for you to apply a minimally invasive strategy, because you're going to do the same size incision whether the person has a BMI of 33.5 or a BMI of 22. It's the same size incision, as opposed to an open TLIF where the incision is going to be significantly larger for the patient with a BMI of 33.5 versus the BMI of 22. So those things do factor into my decision making, but my focus first on this patient would be to have him be as engaged in his health solution as I will be engaged in his health solution, and I would first expect him to lose 12 pounds before we proceeded with surgery. Again, in my hands, with this degree of severe bilateral disease, as well as the severe bilateral pain syndrome that this patient is experiencing, an open TLIF would carry with it the most predictable success for intervention in my hands. There are a number of people who are incredibly slick at these minimally invasive approaches of achieving bilateral decompressions through a unilateral approach. But there's also the alternative of having a tube dropped down both sides, or leveraging the MIS TLIF system that you have at your disposal that facilitate medial fasciectomies, deploying that on both sides, so you basically do a bilateral MIS approach, is another option for addressing this bilateral disease. But in my practice, it would begin by a pause to focus this patient on prehabilitation, weight loss, and maximizing their surgical candidacy, followed by an open TLIF. As you can see, the treating surgeon in this case did in fact do an MIS TLIF at L4-5, used an anterior cage. You can see that they did achieve some disc distraction and restoration of disc height. Also achieved a partial reduction of the spondylolisthesis. And we don't have the precise details on how they achieved the decompression, but it's important for anyone taking care of this to recognize that decompression is one of the 3 critical features of treating this type of pathology. Any concluding thoughts, Aaron?
Well, Dave, I think that was really an excellent point about the importance of prehabilitation, particularly in this patient when it comes to maximizing outcomes and decreasing complications.
The beauty of modern spine care is that we have a number of tools in our tool belts. We have an embarrassment of riches when it comes to options that we know are successful at helping people with these conditions and giving them back a quality of life that lets them move on and move forward. Frank, any final thoughts from your end?
I'd like to thank you both for a very thought-provoking discussion and debate. You both very nicely articulated the advantages, disadvantages of open and MIS TLIF. As we think through this, I think the reality is there's probably a place for both of these in our armamentarium. In terms of TLIF, I think it's important to understand what our surgical goals are. If your primary surgical goal is deformity correction, you really need to critically look at the patient's pre-surgical anatomy and decide whether TLIF is the optimal approach for correcting the deformity. In certain incidents, there may be other surgical approaches that are going to provide better and perhaps easier correction of the deformity. In my experience, and I've done TLIF for a long time, there's a fairly challenging learning curve. I would suggest to listeners on this webinar that are starting off to do the easy TLIF cases first. It's a procedure that takes a while to get comfortable doing and doing well. You have to be able to do good decompression as part of your TLIF when required, and sometimes doing that using less invasive techniques is quite difficult. Once one becomes proficient in MIS TLIF with relatively simple cases, I think at that point it becomes reasonable to entertain the idea of performing MIS TLIF for some of the more complex pathologies we see. Typically, to effect major deformity correction with a TLIF, one must be prepared to take down both facets as well as have instrumentation that allows compression across the construct to optimize lordosis, all accomplished in a less invasive technique. Clearly, there's a learning curve until you should be ready to tackle these complex cases. Thank you all for joining us again for what was a very interesting and topical debate today. Thanks very much for joining us.